with you. Can you see the PowerPoint?
No.
No?
No.
Oh. Whoop. There we go. Screen share. How about now?
Yes.
Yes, yeah.
Okay. All right. So tonight we're going to go over, we're going to cover the electronic health record. Okay. You know, this is one of the main reasons why you're actually taking the course around, obviously, medical office management, but the bulk of this course really is the SIM chart. It's actually learning the electronic health record and what its purpose is and how it's kind of evolutionalized healthcare. So you know, it's really created an advancement as far as we don't have to worry about losing files anymore. We have the information at our fingertips, literally, as long as your systems are up and running. You know, everything's readable, and you don't have to worry about anything mislabeled or you know, prescription orders being inadvertently you know, transcribed incorrectly. The electronic health record, you know, it's the goal. So there really is a goal why we're doing this, and we'll talk a little bit about more as the PowerPoint goes along. It's really around our trying to manage and measure outcomes for patient illness and mortality, and that's deaths. So with electronic health records, the more information we embed into our electronic system wherever you work, whether you work for Hartford Hospital or you work for a private office, the more information you embed into that computer system, and then you start to share it up in the cloud, and if you push information upward, and we can start sharing it amongst each other, you can actually look at disease processes like cancer, heart failure, COPD, chronic obstructive pulmonary disease, and you're actually able to look at those patients over time and actually see, are we really truly making medical progress? So it's one of the big benefits of the electronic health record is the fact that we can now share between more and more facilities. And the government's kind of gotten their hands into it, and you know, good Uncle Sam, but to somewhat in a good way. And we'll talk a little bit more about that as I go along. And you know, obviously your medical record is your lifelong history. It's from the time you're born to the time you die. Most of us, well, not most of us, maybe many of you have health records that are all electronic. Somebody like me, being a little older, some of mine might be somewhere lost in time because they were in a paper chart somewhere. But eventually, most people, you know, depending on their age, most of their healthcare information might be in totality in an electronic format. So this goes back to what I was just mentioning earlier. It's called meaningful use. And some of you, if you work in healthcare now, you might have already heard about this. So this has been around for a little while. It's not new. It's probably around 6 years old. Yeah, just about 6 years old. So meaningful use, I believe, was actually developed in Obama's administration. And the goal, again, was they really wanted healthcare providers to become digitized, to develop an electronic health record. So they had to incentivize everybody because, you know, not everybody had the money to do this. So what they did, they said, well, if you are willing to do this, we will give you, for every provider or every doctor you have, that's a full FTE. That means a full-time provider, 40 hours a week. So every doctor that you had or have, whether you were a health system that owned your physicians or you were a private office that had partners, they would give you $44,000 per physician. So, you know, it sounds great. And well, it was at the time, because if you had a lot of physicians, if you had, you know, 1,000 physicians in a health system, that was a lot of money. So everybody, most everybody jumped on the opportunity and got the $44,000. Well, you had to do something with it, because they weren't just, the government wasn't just going to give money away for nothing, but they gave you the money because they wanted you to become digitized. So you had to put some kind of electronic health record in place. Most of them didn't cost you the $44,000. So you had some opportunity to retain some of the revenue, or not the revenue, excuse me, some of the money from the government, and do what you want with it. But, you know, most did the right thing and really truly invested in computer systems and, you know, storage space, you know, electronic storage space, and, you know, and such. Not that the government's foolish, they're pretty smart. So then the government said, okay, we've now given you all this money. Now we want to see, are you really using it for what it was purpose was for? So they, as time went on, they started putting restrictions in, saying, okay, now you got to prove to us that you are, you know, teaching patients for smoking cessation, or that you are asking your patients to access their electronic portal, you know, to look at their health system online. So there was a lot of measurements that were tied to this, and if you didn't meet the measurements, you actually took penalties. So you might have got all that money up front, but if you didn't do your due diligence and do what you were supposed to do, you were at risk to lose money. So that's the whole point of meaningful use. So you know, the goal to get everybody to do this, once you've done this, again, everybody starts to have this information, and as we start to learn to push it up to the cloud, I'm not an IT person, but I know that, you know, if you want to move images to another health system, you got to push it up to the cloud, and then they've got to download it somehow through, you know, some systems, like I know there's one called Lila. So you push it up to Lila, and if the other hospital has Lila, they can reach out and they can pull it down into their system, and then they can actually read it, because part of it is actually, you know, it means nothing to them if they pull information down and it's not really readable to them. So their system has to be able to read it, because some places might have Cerner and other places might have Epic or another you know, electronic health record. You had to prove that you got some kind of privacy maintenance, and you're able to secure your patient data. But this was really what meaningful use was really about. It's really, I will say, it has done well. You know, it was a lot of money that the health system that was kind of put into the healthcare industry. And you might not have noticed it, but it did happen over time all around us, because you realize it today when everybody goes to the doctor's office now. It's very rare that anybody goes into a doctor's office and somebody sits and looks at you and they don't have a computer next to them and they're typing away. That's because they've been tied to meaningful use. They put an electronic health system in place, and it's now changed their workflow. No more paper charts. Has anybody noticed that when you go to the doctor's office? You know, they're sitting in front of a computer now. They don't just sit there and you know, just ask you questions with their hands folded. They're actually busy working, trying to make sure that they meet criteria for meaningful use. They're asking you about your meds. They're asking you, you know, if you do smoke, you know, would you be willing to try a smoking cessation program? So it's all things the government government really wants us to make sure that we follow up on. So that's meaningful use. So the advantages of there's advantages and obviously disadvantages of an electronic health record. More advantages than disadvantage, I would say, though. One advantage is that it's fewer lost medical records. You know, again, many of you guys are young. You might not remember what an old chart looks like. It looked like a big old 3-ring binder in a hospital. And in a doctor's office, we have, and I'll show you later, we had very simple charts that had a couple of dividers in them, but they were paper charts, and that's what we lived with at the time. We didn't have everything electronic. When we initially started really to look at electronics, a lot of it was around billing and such, and registration. There wasn't really a whole lot initially around patient information and documentation. So a lot of changes have occurred over the years in leaps and bounds, and probably the last 9 years or so. Chart accessibility. So before, in the old days, you had to go to a chart room and you had to pull the chart, or if somebody had the chart, you didn't know where they had it. They could be down the hall, they could be in the patient's room, they could be just about anywhere. Now with an electronic health record, anybody can go in the patient's chart from anywhere. So multiple access. It decreases the duplication of orders because everything's entered in one place and people see the order in one place. It's a very efficient way to transfer records and billing data because again, you can push information from system to system. And you decrease your storage need because all of a sudden the bricks and mortar space that you needed to house all those big 3-ring binder charts goes away. You only really need space for laptops sitting in areas where staff are going to utilize the system to do the work that they need to do. Most of the hard drives are pretty small today, pretty non-existent when you really look at how small they make computers today. So it's not a whole lot of space needed for an EHR. Some of the disadvantages are cost. That is true. So computer systems are very costly, and you got to maintain them. You got to make sure you have backup systems. You got to back up the backup. Because you've got to have redundancy with an electronic health record, because if the system goes down, you need to make sure that you've got the ability to bring it back up. And by bring it back up, most systems will back themselves up multiple times in the day. And if they don't, at least once in the day they back up. And usually that's typically at midnight. The system will do a backup. If your system crashes in the middle of a day, sometimes you might lose everything that you did for that day, but everything from midnight that evening before and back should have been backed up and will be there. It just might require that you're going to have to enter information manually from the time of midnight forward. And again, it depends on how many times your systems back up. Typically, big health systems like Hartford or where I work, Bay State Health, they'll back up their systems every so many hours because it would be brutal if the system went down and you had to back up, 8 hours worth of data. A need for IT support. IT is information and technology. So in the old days, you needed a lot of people to manage charts, put charts together, break charts down. Now you got to have people that are very specialized and they go to school to learn information and technology, and they're the ones that help us with our workflows, try to help us get systems to talk to each other, and see if they can actually integrate, they do some of the back end coding. So a lot of those people are hired to support you. If you're a small operation, you might just lease those kind of people, or the vendor, depending on the company that you choose, they might just send somebody out to you on a routine basis at a cost, but to help you, upgrade your system or just do routine maintenance. So you want to always check for the systems. You want to make sure what you buy fits what you need. Some people want to buy the Cadillac, and you don't always need the Cadillac. You need to buy what you need. You need to buy what you afford, whether you lease it or you buy it. But the wrong fit, you'll know if you got a wrong fit, because the people that will tell you that you got a wrong fit will be the people at the front end that are frustrated with it. Okay. So working with your EHR program, most of the time, when somebody gets hired, they're going to do some kind of orientation process with you, so you at least become familiar with the hardware. And the hardware, remember we learned last week, that's the stuff you can touch, the computer, or the hard laptop or desktop or whatever you're going to work with. somebody's going to show you how to utilize that piece of appliance, whatever you want to call it. They're also going to show you the different opportunities to use it. And by that, I mean the different software packages embedded in it. There might be only one, there might be multiple, but somebody should work with you and do some kind of formal check and balance, and that makes sure that you've been signed off and you know how to use it. Again, we learned about HIPAA, respect for patient privacy and security. You've got to follow the rules. Hopefully your code will change every so many months and force you to change your code. Which is a good thing, because you don't want somebody looking over your shoulder in learning your passcode. And then if it's a passcode you have for life, that means they know your passcode for life too. So it's a good thing to change passcodes every so many months. So always be careful that if anybody's looking over your shoulder. How do I create a new patient record using the existing software that you have? You're going to actually do an exercise in SimChart this week where you actually do register a new patient. You'll be utilizing the SimChart software, but you'll get the patient's insurance card and such, and all their personal information. Most of us have gone to a doctor's office, dentist, or an eye doctor, and you've sat out in the waiting room, and they gave you a little clipboard, and you fill out that pertinent information. This is the kind of thing you're going to do this week with SimChart. This particular, I forgot her name. The patient is a new patient in the office, and so you're going to be filling in her patient information, and you'll be doing her demographic information from her face page. And the face page is, like I said, it's that kind of a clipboard concept. A lot of offices have actually moved away from the clipboard, and they'll give you a like an iPad, and you can do your registration from an iPad. But most places still have the clipboard concept, and then somebody behind the office is entering everything manually into their electronic health record. Correcting electronic health record, so just like a paper chart, I know that hopefully the MAs have heard the rules. We never erase in the medical record, ever, ever, ever. You never erase. You can do a cross out. You can document what was supposed to be there. Then you initial it, date, and sign it. You never erase. So the same thing holds true for an electronic health record. The minute you hit enter, that information is locked in there. There is no way you're going to be able to get it out of there. So the only way you can correct information around a result or anything in an electronic health record, there needs to be an addendum. And addendums, by choice of the institution, can occur at the end or at the beginning of the documentation. That's dependent on the institution you work for. So I'm going to, maybe somebody's blood test came back with an erroneous result, and you want to put in what the result should have been. Again, it's an additional line stating that the above or the below information was incorrect, and this is the correct information. Most places like to put addendums at the very start of the document. Some places choose to do it at the bottom. I recommend the start, and the reason I recommend the start, if you don't scroll all the way to the very bottom, you could miss it. Most people start at the top of anything that they're reading, and hopefully they'll catch the error that actually occurred. So in the electronic health record, so the practice management system, so you're going to pick customized templates. I do know when you start to customize systems, they call it the GUI. When you start adding things on your screen pages that are specifically, trying to think of an example, logos. I think Hartford Health is 2 H's combined against their letters or something like that. I know, so where I work, Bay State Health, our logo is, two adults, and then on either side of them is holding 2 small children. But they're like small little caricatures, but they're logos. If you want that kind of stuff to be on your screens of your electronic health record or on your reports, or if you want, like if you've got if you're registered with a certain society, or you've received some accolades or maybe awards, national awards, and they put those kind of things, they're called the GUI, and it costs you money. The minute you modify their canned report and you start moving things around, it comes at a cost. It can get very costly, but it can be done. But you can buy all sorts of things when you're buying software: billing, coding, report generation, to generate any kind of imaging reports, CAT scan, CT, MRI, EKG, whatever kind of report you want to try and generate. So you can work with them. Most of the time they do have what I call a canned report, where it's very simple, but it's really hard sometimes to buy the canned report, and most people will make some modifications. But again, modifications come at a cost. Ancillary order integration, and patient access. So access is access to care. That's what they mean by patient access. That's getting appointments in. The rules around access to care for medical offices are, not rules, that's the wrong word I'm using. The standard quality measurement for access to care to get into a doctor's office is less than 14 days. If you try and get into an office for, I don't know, whatever you're going for, a mammogram, or no, that's a test. You're going there just for your physical. Well, that's a bad one. That's because you could have that a year from now. I don't know. Let's just say you're having belly pain or abdominal pain. If they give you an appointment greater than 14 days, that means they've got a hard time getting their patients in. So the average office, if they are managed well, if they have the right amount of doctors and the right amount of staff, a doctor's office should be able to get you in under 14 days. It's not always, it's pretty hard to do. I can tell you, even for many of the offices that I manage, it's a challenge because if you don't have, again, enough doctors or staff, that's a hard nut to crack. Imaging, to get in to have imaging done, that is 7 days or under. And the reason it's shorter is because, so when you go see your doctor, they typically, say it took you 14 days to see that doctor. If they want you now to have a lab test, if it takes you more than 7 days, you could be going almost a month looking to try and understand what's going on with you. So that's why they try and shore up any kind of procedure or imaging or any kind of labs. Or labs you should be able to get immediately. And most radiology procedures like x-rays and such, you can get in as walk-ins. But things like CT, MRI, echo, vascular ultrasound, general ultrasound, sometimes they can go beyond 7 days. But the industry goal is to try and have you get them under 7 days. And that's what they call patient access or access to care. Let's see. Well, you want to make sure you want to reassure others about your ER's confidentiality, and the others really are the patients that you serve. They want to trust that you're not going to give out their medical information and that your system isn't weak enough that others from the outside can actually tap in and get into your system. It happens. I know where I've worked, we've had a couple of breaches, and if it does happen, you've got to notify the patients that were actually breached and let people know that their information was seen. We had one a couple of years ago where they were able to get demographic information. They weren't able to get any medical information, but demographic information can be just as bad. That's your phone number, address, credit cards, all sorts of things. So what we did, because it was significant. I think it was like 5,000 patients or something. We offered, we gave them all free internet protection for their information. So because it puts them at a really awful risk, because if somebody was able to get their system and print it all off, we would have a hard time, and as would they, trying to know who was going to use it or not use it. Let's see. You would probably create a pamphlet. Your office would probably have something explaining something about your electronic health record. And the reason you'd want to do that with your patients is most of us want our patients to go out on their electronic health record. Has everybody ever accessed their own health record? Yep. So I'm ashamed to say I haven't, but you know, it is commonplace. So you guys, you're a whole lot younger than I am. This technology is normal for you, and it's clearly evident that the generation growing up now is very comfortable with you know, going into computer systems, and if they want to look up and see what their test result was or is. So that would be an important thing to offer your new patients some pamphlets or some information. And pamphlets are actually kind of old school. You might even give them a business card now and say, and it might say, you can go to www. Hartford Health something and log in as yourself and see your own medical information and such. So obviously that's part of maybe their first time in the office. You might demonstrate how they actually access the portal, so they can actually go in and know and get kind of comfortable going in their own electronic health record. And then when it comes to employees, you always want to explain the audit trail and how pertinent information is released. And I explained to, I think last week, you know, typically how we audit people is we typically start off, the programs run name to name. They'll run the programs will run employees' names and just see if they're accessing employees their own personal names from their own family. So, you know, that'd be an audit trail. Okay, so that's our electronic health record. So that was pretty easy. I am going to assign you 2 SimChart assignments. Well, I guess I should ask you, any questions on this chapter?
No.
No. Okay.
No.
All right, certainly not the most exciting, but it's important. The big part I really want you to focus on, and I'll tell you the pages in the book. I can't remember them. I'll send you an email. The pages in the book around the meaningful use. I do want you to focus on it because it was a 3-step process when it was first put in place. I think it started in 2014. I think. All right, so. In the SimChart book, I'm going to give you 2 assignments. I'm going to give you on page 79, I want you to complete a new patient registration and schedule an appointment for Lisa Ray. So you've already learned how to schedule an appointment. So now this time around, this lady's coming in brand new. So she's not going to have ever been in the practice. So I'm going to have you do that one, and that's going to start on page 79. And then I want you to go to, the next one you're going to go is going to be to do a prior auth. And that one is on page 86. And I don't know if everybody knows what a prior auth is. So insurance companies, as part of their for better for worse, they're kind of watching us and how we, I should say, how physicians order tests and procedures. And there's really a logical way for them to actually do it. Some physicians, you know, in a prior history would jump to the most expensive test. And it was really a poor use of healthcare dollars. So many insurance companies came up with a variety of processes. So it's kind of how you slowly phase in what a physician can really do, and when it comes to ordering procedures based on a diagnosis. So with most procedures, and it's becoming very commonplace for almost all procedures, except for some very small ones. You need to get what's called a prior authorization. So it means that the ordering office, has to call the insurance company, explain to the insurance company what the doctor wants to order on you or the patient, and then they have to wait to find out based on the request and the diagnosis, will they authorize it? If you do the test and they did not authorize it, then the patient is at risk to pay the bill. So this is why it's so important that a prior auth is done. The only time a prior auth a prior auth is waived is an emergency room visit. So if you go to the emergency room, there is no prior auths. They're typically done. So if a doctor in an emergency room needs to do a CAT scan on you or an MRI, you can have the test done, and you are not subject to a prior auth. But when you are an outside ambulatory patient, you are held to a prior auth and to the restrictions of your insurance company. Does that make sense, everybody?
Yeah.
Okay. All right. So those are the 2 assignments I'm going to release. So I will release these after we're done here. You know, like I said, you're doing well. I don't see any problems. Take your time with this one that you're going to do. Well, whenever you do it. The registration on the new patient. I forgot what her name is. Lisa Ray. You know, just take your time. It's a short assignment, but you got to keep going back and looking at her demographic data and putting her correct information in. And if you miss one of the steps, I'm pretty sure it will. It won't move along. Make sure you fill in her phone numbers. I think you have to make sure when you do this, the zip code, you got to put the additional, was it additional 4 numbers at the very end? I can't remember how a zip code is shown now. Well, you'll see it when you go to put her zip code in. Does anybody have any questions for me? Okay, this is all I have tonight for you. You know, you guys finished your exam. You know, so that was a good part of your week. You know, we're just starting again for exam 2, so we got a little while longer before you'll actually have that, and we'll be just doing the next 3 chapters before we have exam 2. Okay.
Thank
Thank you.
you.
All right.
Thank
All
you.
right.
Good night, class.
Good night now.
Good night.